really matter? In most cases, probably not. But for surgical patients, 1 degree can make all the difference. Even a small drop in core body temperature can lead to unintended hypothermia, a condition that's potentially harmful to patients and costly. That's why it's critical to keep patients in the normal thermic temperature zone before, during, and after surgery. With the 3M Bear Hugger Normothermia system, you can own the zone by providing active warming and consistent core temperature monitoring throughout the perioperative journey, with the goal of maintaining core temperatures between 36 and 37.5 degrees Celsius. When outcomes are on the line, every degree matters. And the products and processes you use matter too. Choose the most trusted name in patient warming. The solution that's been used to warm more than 200 million patients and empowered countless clinicians to confidently own the zone.
Good morning, everyone. Welcome to the Lunchtime Symposium of ASPA 2021, proudly sponsored by our gold sponsor 3M this year. Keeping true to the theme of our conference, we continually seek to find ways to improve the perioperative outcomes of our little ones. It may not be anything complicated, nor even obvious unless you look out for it. And for us today, it is temperature control. So to help us with this, we are very honored to have with us today Professor Anselm Bauer from Germany to share with us the topic of perioperative hypothermia in children, its history, actual problems, and prevention. Professor Bauer is consultant at the Department of Anesthesiology at the University Hospital in Göttingen, Germany. Having completed his specialist training in anesthesiology, he went on to acquire additional titles in emergency medicine and intensive care medicine. In the last 20 years, he has conducted many clinical trials and published about 50 articles about hypothermia. He is co-author of the German and Austrian Guideline for the Prevention of Perioperative Hypothermia. And most recently, he is the author of the first book worldwide about perioperative hypothermia and perioperative temperature management. So without further ado, let us welcome Professor Bauer.
And welcome to this satellite symposium about perioperative hypothermia in children. My name is Anselm Bauer. I'm working as a professor of anesthesiology at the University Hospital in Göttingen in Germany. Now, in this presentation, I will talk about the discovery of perioperative hypothermia and its serious adverse effects in children. I will talk about the incidence of perioperative hypothermia in children today. I will talk about the importance of perioperative hypothermia prevention, and I will mention or discuss the most important measures to avoid perioperative hypothermia. That is an adequate room temperature, active pre-warming before induction of anesthesia, warming therapy during anesthesia and surgery, in some cases fluid warming, and the measurement of core temperature. And I will make some remarks about the cost efficacy of active warming therapy. Let's start with the history. If you take a look at the history, you can see that there is a clear sequence of events. In 1847, perioperative hypothermia was discovered, and about 100 years later, in the 1950s, it was recognized that severe perioperative hypothermia can really be a threat to small children. And in the same years, in the 1950s, the first measures against the development of perioperative hypothermia were developed, and they were mainly tested in children because children are so susceptible to develop hypothermia. In the early 90s, there was a recognition that even mild perioperative hypothermia is really a big medical problem. And then we started to treat first postoperative hypothermia, then we started to prevent intraoperative hypothermia, and then active pre-warming was added. Now, I already said perioperative hypothermia was discovered in 1847, only 1 year after the first general anesthetic was performed. And to the best of my knowledge, this is one of the longest known adverse effects of general anesthesia. And perioperative hypothermia was described by these two gentlemen, Ernst von Bibra and Emil Halles, in 1847 in Erlangen in Germany. They found out in animal experiments that the core temperature in these rabbits dropped under the influence of ether by several degrees. So this is a clear description of perioperative hypothermia. However, for a very long time, perioperative hypothermia was not recognized or realized that it is really a relevant clinical problem. Nearly 100 years later, pediatric anesthesiologists realized that severe perioperative hypothermia can be a life-threatening complication. In 1957, France published a case series of 12 newborns where they described severe perioperative hypothermia. The core temperatures of these newborns ranged between 36.1 and 28.6 degrees Celsius at the end of the procedure. And 4 of these 12 children had core temperatures below 30 degrees Celsius, which is really severe perioperative hypothermia. And the authors wrote, of the 5 deaths in this series of 12 patients, 2 were directly attributable to surgical causes. In 2 others, failure to rewarm and stress to transfer to a colder incubator may have been important factors in causing death. I think today we have a clear idea why these children died, because we know that severe hypothermia in newborns is associated with increased oxygen consumption, increased carbon dioxide production, and increased plasma levels of norepinephrine. And the release of this norepinephrine triggers vasoconstriction, which leads to anaerobic metabolism, acidosis, and it leads to pulmonary vasoconstriction, pulmonary arterial hypertension, right to left shunting, and hypoxemia. And this is really a life-threatening combination of complications for newborns. In the next years, we learned that cold OR temperatures increase the risk of getting hypothermic. Harrison reported that already in 1960, and this is something that we still can see today. In this study, we also saw that long operation times facilitate the development of perioperative hypothermia, which is probably due to the fact that these children were not adequately warmed, so they were not in a thermal steady state, and they cooled throughout the surgical procedure, and the longer the procedure lasted, the cooler the children got. And we also learned that small and low-weight children were especially at risk, something that we can still see today. In the same years, in the 1950s, the first measures for the prevention of perioperative hypothermia were developed, and they were developed first for children because children are so susceptible for the development of perioperative hypothermia. In 1953, Behring and co-workers developed a conductive warming device that can be placed around the chest. And they saw that without this active warming, the core temperature of a child dropped, as you can see on the right side of the slide, whereas with this active warming device, they were able to maintain core temperature. In 1973, a prototype of a forced air warmer was described for newborns. You can see on the left side the control unit and the so-called warm air bed, something that looks very, very similar to forced air warming devices with underbody blankets that we see today. However, it still took a long time to get efficient, reliable, commercial available warming devices. So we see that it takes sometimes very, very long until good ideas get into clinical practice. And to get warming therapy into clinical practice, it needed more arguments. In the early 90s, several studies were published that clearly showed that even mild perioperative hypothermia is dangerous. For example, Steve Frank published a series of articles that clearly showed that patients that are at risk of coronary heart disease have more myocardial ischemia in the postoperative course, and that they have more often arrhythmia and so-called morbid cardiac events, which is unstable angina, myocardial infarction, and cardiac arrest. And in the same years, there were two landmark trials that clearly showed that mild perioperative hypothermia can lead to surgical site infections, which is a big problem even today. Surgical site infections are one of the most common nosocomial infections in the hospitals. And it was also shown that mild perioperative hypothermia can inhibit coagulation and increase blood transfusion rate. This is caused by a reduction in platelet function, by an inhibition of plasmatic coagulation, which leads to longer bleeding times, increases blood loss, and can increase transfusion rate during major orthopedic surgery, major abdominal surgery, and cardiac surgery. So these studies were really a kind of a wake-up call for the community. And as a consequence, effective warming devices that were already on the market were improved, were developed, and warming therapy really expanded in the 90s of the last century. And first, these devices were used for postoperative rewarming and the therapy of shivering, because many people thought at that time that these cardiac complications were mainly caused by postoperative shivering, something that we learned in the last years isn't really true. But at that time, people thought that, and now also thought that this was one of the most important reasons for that. Later, the devices were used for the prevention of hypothermia during anesthesia and surgery. And later on, when we discovered that this really does not the job alone, active pre-warming was added. So the problem should be solved, right? After 70 years of research and with all the warming devices on the market, unfortunately, I think this is not true. The problem is not solved. If we take a look at data from the last 10 years and take a look at the incidence of postoperative hypothermia in children, we can see in several studies that the postoperative hypothermia rate ranges between 3% to 52%. And we see that there are large differences. Some studies find a relatively small incidence, whereas others about 50%. And we should notice that the rate of intraoperative hypothermia is always as high or higher than the incidence of postoperative hypothermia. So when you see a hypothermia rate, a postoperative hypothermia rate of 50%, probably the intraoperative hypothermia rate was 60 or 70%. If we take a look at the data about the incidence of postoperative hypothermia in smaller children, in neonates and babies, we see nearly the same pattern. We find some studies that have a low incidence of postoperative hypothermia, ranging in between 4% and about 20%, whereas some other studies have incidence of more than 80%. And once again, the intraoperative hypothermia rate is even higher. And the intraoperative hypothermia rate is probably more important because the bleeding occurs during the operation. The risk of surgical site infections is mostly during the operation. So this is really, really dangerous. But if you take a look at these data and think about what these data really mean, I think it is clear that the rate of postoperative hypothermia depends very much on the actual warming strategy and less on patient factors like age, weight, or surgical procedures, because you see there are some clinicals, research groups that find low incidences, whereas others have really high incidences. So I think strategy is really, really, really important. However, patient factors are still important. We can see, for example, in daily practice, that neonates and infants can cool much faster than children or adults. So age and weight are important risk factors for the development of perioperative hypothermia. And if you ask why neonates and small infants develop perioperative hypothermia so fast, you can think about whether it is a problem of the developing thermoregulation, or you can think that it is more a problem of the anatomy of the child. If we take a look at the data that we have, we can see that thermoregulatory vasoconstriction, which is one of the first countermeasures of the body against the cold environment, is already present during the first day of life, in the premature and in the full-term neonate. So thermoregulation is there. The thermoregulation thresholds are relatively comparable to adults, so it seems to work quite the same way. And thermoregulatory vasoconstriction also leads to reduction in conductive and convective heat losses in neonates, which means it is working. However, we see from daily practice that it is not working as good as in adults. And I think the most important reasons are anatomical reasons. For example, we know that preterm neonates have only a very thin layer of subcutaneous fat and a reduced keratin content of the skin, which results in an increased thermal conductance and increased evaporative heat loss. And evaporative heat loss is very, very important because it is a very, very effective measure to lose heat. In addition, neonates and infants have a very large body surface area compared to their volume or the weight of the body. You can see on the right side of the slide that the ratio between body surface area and weight is about 3 times higher in neonates compared to adult. And I think these factors, the anatomical factors, are really the important factors that make our small patients so susceptible for getting hypothermic. Now, if we take a look at the typical risk factors for the development of perioperative hypothermia today, we can still see from a large study from Singapore, from Dr. Lee, that the risk factors are low body weight, low operating room temperature, no intraoperative active warming therapy, and no good passive insulation, and no intraoperative temperature monitoring. I think this is very, very interesting. And I think this is very important. I will come back to some of these points later on. I would like to stress again that severe perioperative hypothermia can lead to life-threatening complications in neonates. The cold stress that these neonates then have increases metabolism, increases oxygen consumption, increases glycolysis in order to get the energy produced, and can lead to hypoglycemia. The cold stress leads to a release of norepinephrine, which leads to vasoconstriction, anaerobic metabolism, production of lactate, and to acidosis. And it also leads to pulmonary vasoconstriction, and cold stress can also reduce surfactant production. And these two factors, reduce surfactant production, atelectasis, and pulmonary vasoconstriction, increase pulmonary right to left shunting and can lead to hypoxemia. Once again, a potentially deadly combination of problems. In older children, the problems that are associated with perioperative hypothermia are more like in the adults, where we can clearly see that hypothermia is associated with less thermal comfort in the postoperative phase. It is associated with postoperative shivering. But more importantly, there are some severe adverse outcomes that are associated with hypothermia, like increased cardiac morbidity, higher incidences of surgical site infections, and more intra and postoperative bleeding, and a higher transfusion rate, and higher treatment costs. Now, if we take a look at the data that we have for children, we can clearly see that children also have less thermal comfort when they're cold, no doubt about that. There is an increased rate of postoperative shivering when infants and children are hypothermic. That's also very, very clear. But if we take a look at the more important adverse outcomes that are associated with hypothermia, well, I don't think that normal children without congenital heart disease have an increased cardiac morbidity, because the reason for this cardiac morbidity is coronary heart disease. We are also not really sure whether small children have a higher incidence of surgical site infections when they get cold. But we have only a few studies that have tried to find out whether this is the case or not. But we know for sure that there are no real differences in the coagulation system between children and adults. And in children, we also have the reduction in platelet function when the children are hypothermic. We also have this inhibition of plasmatic coagulation, and we can also see that there is increased blood loss during major surgery. And in some cases, in some types of operations, there are more transfusions given to patients or to children that are hypothermic. And we know very well that transfusion itself is also associated with adverse outcomes. So if we want to avoid these adverse outcomes, the question is how we can manage or do our thermal management in neonates, infants, and children to avoid these complications. And the answer is relatively simple. It is nearly the same way as we do it in adults. A good perioperative thermal management strategy consists of 5 simple but essential parts, and each and every of these parts is necessary to get the success. The first part is the part that is really a bit different to adults. The first part is adequate room temperature. We know very well that the thermoneutral temperature in adults is about 28 degrees Celsius. That means that an undressed adult in a room with a room temperature of 28 degrees Celsius is in a thermal steady state. The heat this person produces equals the heat that gets lost to the environment, so the patient or the person is in a thermal steady state. And we also know that neonates and babies have a higher thermoneutral temperature. For example, a newborn with a body weight of 3 kilograms has a thermoneutral temperature on the day of birth of 34 degrees Celsius. And this temperature gets a little bit down in the first month, down to 32 degrees Celsius. That means if the room temperature is colder than the thermoneutral temperature, more heat gets lost than heat that is produced. And as a consequence, hypothermia will develop. Unfortunately, anesthesia reduces heat production, about 30% roughly, thus increasing the thermoneutral temperature of an anesthetized newborn very much. So we usually cannot operate children and newborns in an OR with a thermoneutral temperature. But still, an adequate room temperature is really essential. It is essential, but not enough, because we need other measures for the protection against hypothermia. But we can see, even in the newest studies, that low operating room temperatures increase the risk of getting hypothermic. For example, if you compare room temperature of 21 degrees Celsius with room temperatures of more than 25 degrees Celsius, you can see that the odds ratio of getting hypothermia is about 2. So it is more the factor 2 that it increases the risk of getting hypothermic. And the smaller the children are, the more important is that factor, room temperature. So it is especially important in newborns and babies. Therefore, several guidelines recommend to use high room temperatures for pediatric anesthesia and surgery. And for example, the German, Austrian, Swiss guidelines recommend at least 24 degrees Celsius. Now, the second part that is really important is active pre-warming before induction of anesthesia. We know that induction of anesthesia leads to a phenomenon called redistribution of heat, which means that heat goes from the head and the trunk of the body to the arms and the legs, and at the same time, the temperature in the core of the body drops. The problem is that children already start to lose heat on the way from the normal ward to the operating room due to cold environmental temperatures, due to insufficient insulation, and they will arrive very often with an already activated autonomic thermoregulatory vasoconstriction. And this autonomic thermoregulatory vasoconstriction, together with their clothing, will keep the core of the bodies of these children warm. So they have a warm core, a warm head, a warm trunk, but the arms and the legs are allowed to get colder and colder. Now, all anesthetics interfere with autonomic thermoregulation. That means induction of anesthesia switches this already activated thermoregulatory vasoconstriction off, and then heat flows from the core of the body to the arms and the legs, and the core temperature drops. Active pre-warming can reduce this redistribution of heat because active pre-warming increases the heat content and thereby the temperature of the arms and the legs, and the temperature gradient between the core of the body and the periphery is smaller. And this temperature gradient is the driving force for this redistribution of heat. So if this temperature gradient is small, there will only be a small amount of heat redistributed from the core of the body to the periphery, and the drop in core temperature will be small. Now, you may say that especially in newborns and small children, the head and the trunk is relatively large compared to the arms and the legs, and that this will probably reduce the amount of heat that can be redistributed from this large trunk and head to the small arms and legs. And therefore, you may say pre-warming is not so important in small children. Well, in principle, you are right. However, if you undress a baby in the OR, even if the OR temperature is about 24, 25 degrees Celsius, the children is no longer in a thermal steady state. It loses more heat than it produces, and it will start to cool down. So you will need external warming therapy to maintain normothermia, even before induction of anesthesia. So you may call this active pre-warming, you may call it external warming therapy, but in principle, it's the same measure. You have to warm the child, the baby, with an active measure before induction of anesthesia. So do it. And this is really easy if you're using these forced air warming underbody devices. You can just place the child on the blanket and actively warm the child. It is no big deal. During anesthesia and surgery, we have to warm our children because our anesthetics reduce heat production. The heat losses usually exceed heat production, and unwarmed intravenous fluids further can contribute to the development of perioperative hypothermia. So therefore, we have our child not in a thermal steady state, and we have to restore the thermal balance with active warming therapy like forced air warming and sometimes infusion warming. So if you have already actively pre-warmed the baby, warm the baby or the child during induction of anesthesia, it is totally easy, no problem. And you should also warm the child actively during positioning, warming, and draping. There is no reason why you shouldn't do it. The fourth part is infusion warming. Now, very often in children, an intraoperative maintenance of infusion of about 10 ml per kilogram and hour is used. This is a relatively high infusion rate. If you would calculate that for an adult with 70 kilograms, this would be 700 ml per hour. So most of the guidelines would clearly recommend, at least in adults, to use an infusion warming device. However, many pediatric anesthesiologists do not use infusion warming for the background infusion. And these working groups do not have a high hypothermia rate, because if you warm the child consequently with forced air warming, the heat losses of that background infusion usually can be offset by the forced air warming. But this situation can change dramatically when massive fluid and blood administration is necessary. Then it really gets particularly important to warm these blood products with a blood and fluid warmer. Now, think about infusion warming. It is important to know that the heat loss by unwarmed fluid depends very much on the volume and the temperature of the fluid at the IV cannula. Now, in pediatric patients, the flow rates, the absolute flow rates in ml per hour are relatively small compared to adults. So therefore, we have to pay special attention to the length of the infusion tubing after the heat exchanger of the fluid warming device. Because if this length is, or if this part of the infusion warming device is long, relevant heat losses can occur on the way from the heat exchanger to the IV cannula. I think it is also important not to use infusion warming devices that can release aluminum into the infusion. Aluminum is toxic, and therefore these devices should no longer be used. The fifth part that is important for the maintenance of normothermia is the measurement of core temperature. And you may ask why. I mean, measuring core temperature does not keep any child warm. That's true. But if you don't measure core temperature, you will not be able to detect hypothermia. And you will not be able to determine the relevance of the problem. And you won't have the possibility to control if your thermal management is working or not. And you will not be able to recognize if you are overheating a child, something that can happen. If you want to measure core temperature, there are several monitoring systems and monitoring sites that are acceptable, accurate in neonates, infant, and children. For example, distal esophageal temperature is very, very good. Nasopharyngeal temperature is very accurate with cuffed and uncuffed tubes with laryngeal mask airways. You can use zero heat flux thermometers on the head. You can measure core temperature in the mouth and at the tongue. You can measure it in the bladder, in the rectum, at least in children up to 2 years, or in the axilla in neonates. I already said the avoidance of overheating is only possible if you are measuring core temperature. And I already told you that small children have a large body surface area to weight ratio. This is the reason why they cool so fast, but it is also the reason why external warming therapy can be very, very, very effective, because active warming via this large body surface can be very, very efficient. And this can lead to overheating. And therefore, you have to measure core temperature, and you have to react to that core temperature and turn the temperature of the active warming device down when core temperature rises and rises. Now, very often the discussion arises about cost of warming devices and cost efficacy of warming therapy. Now, the British NICE Institute has tried to calculate the costs and the cost efficacy of active warming. You can see on the left side the costs of forced air warming and other warming devices, which is quite simple to calculate. On the right side, you can see the costs of complications, and you see that the complications that are hypothermia associated are very, very high. But the problem is, how often do these consequences really occur? So the British NICE Institute has tried to calculate several model situations for younger patients, elderly patients, patients with the age of 50 years for minor, intermediate, and major surgery. And they came to the conclusion that in each and every of these situations, forced air warming was cost effective. It was cost effective even when the risk of perioperative hypothermia is low, even when the risk of cardiac complications is neglectable, and even if the duration of anesthesia is short. It is always cost effective. The problem is data from children are lacking, and I think we will never get them. But personally, I'm convinced that the avoidance of hypothermia and the avoidance of these hypothermia-associated complications is also cost-effective in pediatric anesthesia. So after roughly 40 minutes, I come to the conclusions. I think perioperative thermal management in neonates, infants, and children is important because there are several adverse outcomes that are clearly associated with perioperative hypothermia, especially in neonates. Still, the thermal management is relatively comparable to adults. It consists mainly of 5 important parts: an adequate room temperature, active pre-warming before induction of anesthesia, active warming therapy during anesthesia and surgery, the use of fluid warmers when larger amounts of fluids are used, and the measurement of core temperature to control the effects of warming therapy and to avoid overheating. And although this refrigerator magnet that you can see on the right side is from NASA, this is really no rocket science. It's basic medicine. It is easy to do, and it is clearly successful. And I think we should use this approach to prevent hypothermia in our children because they deserve it. Thank you very much for your attention.
Thank you, Professor Bauer, for a very insightful talk. For me, temperature control has never been a walk in the park, especially in children. So I would like to ask Professor Bauer a few questions. And I have grouped them according to the 5 important aspects of temperature control measures that you have shared with us in the talk, Professor. So the first question is with regards to active warming. You mentioned that warming therapy during anesthesia, it's a very important component. And I would like to ask if forced air warming is truly the most effective way to maintain core temperature and prevent hypothermia.
Well, it is at least the most used approach for the prevention of hypothermia. And I think it is the most flexible approach because you can use a very large body surface to actively warm a child. Alternatives are conductive warming devices that are used more in adults than in children that have the problem that they only warm at an area where the skin has direct contact to the warmer. And the other alternative is radiative warming, but radiative warming with these radiative heat lamps causes a spot of heat and only warms special areas of a child. So you get the largest area with forced air warming, and therefore it is the most effective way to do it.
I see. So are radiant warmers still up to date, or should they just be used in a specific population like neonates?
Well, in our clinical practice in the OR, we do not use them anymore.
Why so, Professor?
Because our impression is that we can get along very good with forced air warming because we have a large area where we can warm the child. You don't warm the surgeon or the anesthesiologist or the nurses that get in the way of the radiant heat. It's comfortable, and our impression is it works better.
Okay. So even for neonates, you would use the forced air warming
In the
methods.
OR, we do that, yes.
Okay. Are
In
there
the
any concerns with the use of forced air warming in children, like in causing burns or increasing the risk of surgical site infection?
well, the risk of burns with any form of warming devices is a general risk. If you're applying heat to a body surface, you can cause a burn, especially when you apply very much heat to a small area, and in this area the blood flow cannot transport the heat away, so then the temperature rises and a burn can occur. If you think about the risk of burns, especially the combination of heat and pressure is important, because if you compromise microcirculation, the heat cannot be transported away, so the combination of pressure and heat increases the risk of burns. So therefore, the risk of burns is a bit higher with conductive warming, because there is the direct contact and there can be pressure. Radiant heat or forced air warming is pressure free, so therefore this reduces the risk. And if you take a look at the data from adults, we can see that about 80 or 90% of all burns that have occurred with forced air warming were induced by a process called free hosing, by using a forced air warmer without a blanket, something which is not allowed by the manufacturer and is clearly a misuse of the devices. In general, burns can also occur in children, but there are no reasons to think that the risk is higher than in adults.
Thank
Especially,
you. Mm.
just one remark, especially if you think about the high efficacy of forced air warming by using this large body surface area, so that you can relatively easily reduce the temperature of the active warming.
All right. Thank you very much. Now, maybe we look at another component, that's infusion warming. I have a question here from Dr. Serpil. She says, may I ask whether there is a practical, small and lightweight way of warming fluids, because they are so heavy for tiny IV lines?
That well, that is true. Yes, and I think the honest answer is all of these fluid warming devices that I am aware of, or most of them, have a heat exchanging unit that is relatively heavy. So it is very, very important to place this heat exchanging unit in a way that it cannot tear at the IV line of the child.
I think in our unit, we actually warm our fluids previously using a warm water bath, but now we do have devices that we actually like. It's like a hot plate device, but it's not so hot. We place the fluids, the bags on these heating devices, and it keeps the fluid warm, so that when we hang it up, it is already a pre-warm fluid. So it is not an inline fluid warmer.
Yeah, this is helpful. However, if you're using very low infusion rates, the fluid will cool down on the way from the bag to the IV line. However, if you have a warm room temperature, it will only cool down to room temperature, not lower. And I think it is important to realize that in most of the cases, usual surgical procedures in small children, you do not need really an infusion warming device. You will only need it if you have to add a lot of fluids because major oncology surgery with massive bleeding, then it gets really important. Then your flow rates will be high, and then pre-warmed infusions will also be beneficial, clearly beneficial.
Right. Thank you. I have another question here about your opinion of the use of still asking about infant warmers for neonates. I think what she meant is whether you can use the infant warmer um, rather than forced air warming. Maybe I think what she meant was putting the radiant warmer over the baby during the operation.
It is generally possible. We did that many years
Yes,
in our daily
we still
practice.
do.
It works. There is no doubt about that. You have a little bit of heat to the head of the surgeons and to the hands of the surgeons, of course. But it works, and you can adjust the efficacy of radiative warming by adjusting the distance between the warmer and the child, and you can of course also measure core temperature, adjust your warming therapy. It works, no doubt about that.
Except the surgeons will be sweating under their surgical gowns.
Yeah.
Okay.
And I think it's not very likely that you can position the radiant lamps in a way that you will warm the child efficiently without warming the surgeon.
Warming the surgeons. Yes, I agree with that. So, one question about active pre-warming, which is another important tenet of the five strategies you mentioned. What is the difference between active warming therapy before induction of anesthesia and pre-warming? Are they the same?
Well, it's a difference in the words that you use, but from a technical point of view, it is really the same. You're applying heat to the child before induction of anesthesia to maintain core temperature. And if you do that in an efficient way, you will get a warm periphery of the body, so the redistribution of heat after induction of anesthesia will be small. But from the technical point of view, it's really absolutely the same measure.
Okay, so it's the same. Except that I find that in our unit, pre-warming young children is quite a challenge to administer because they are running around anxious in the waiting room, and they will not keep still to be warm, lying on the blanket or have it over them. And also, we have limited active warming units, and if we don't supervise them, it's also quite hazardous because the hot air might be blowing on them directly. So, what is your advice to units with no resources nor manpower to give pre-warming to pediatric patients?
Well, we don't pre-warm small children, for example, in the holding area. We started in the OR. So we bring the child with the mother in the OR, and at the time when you have to at least partially undress the child, we place them on these underbody blankets, and the blower is already turned on, so the blanket is warm. This is a nice warm feeling, and from that point in time on, we are actively warming the child. When we partially undress the child, when we place monitoring, when we're talking to the child, when we start induction of anesthesia, and this is the time where we do it. Otherwise, I think the efficacy would be low because probably if you have small children and they're
Yeah,
running
they'll be
around,
running around. Yes.
they won't do what we want
They
them
won't
to
keep
do.
still.
So this is something that we don't do. And therefore, we have only one blanket, one blower unit for pre-warming and intraoperative warming therapy. So if you are using the blanket and the blower, you can turn it on before induction of anesthesia.
Okay. I have a question here from Dr. Akhtar. She asks, bear hugger have temperature range as high as 41 degrees. Is it okay to go as high as 41 degrees for neonates? Because I think we learned that they actually warm up very quickly as well, as fast as they lose heat.
That is correct. I usually start with the highest temperature and monitor core temperature. And if I see core temperature is rising, I reduce temperature because the goal is not to get the child up to a core temperature of 39 degrees Celsius, but to maintain normothermia. And very often you can really step down with the temperature relatively quickly and maintain normothermia by that way.
Okay.
But you have to measure core temperature.
Yes. Coming to measurement of core temperature, I do have a question. What do you recommend is the best core temperature monitor for the asleep child versus the awake child?
That's a difficult question. I think what is the best way to do it? I think first it is important that you are using a measurement site that is far away from the operating field. For example, during lower abdominal surgery, something like bladder temperature will not give you the correct core temperature because the surface of the bladder is exposed to the air, the bladder cools down, so therefore it is important to measure far away from the operating field. Esophageal temperature is said to be very precise. However, if you have intrathoracic procedure, it is surely influenced. These newer zero heat flux thermometers that are placed on the forehead are very interesting and have one big advantage over all other measures. They are non-invasive, and you can use them at least in older children, for example, also for the measurement of postoperative core temperature. But they have the big advantage that they are non-invasive. If you're using, for example, nasopharyngeal temperature, you have a risk of causing nose bleeding. If you're using esophageal temperature, you have the risk of misplacing the probe in the mouth, in the trachea, whatsoever. And this is also avoided by the use of these newer heat flux temperature monitors.
Thank you, Professor. I think we are actually running short of time, so I'm afraid that will have to be the last question. Thank you for sharing your time with us today in this live Q&A session and for enlightening us with your talk. I'm sure it will go a long way to keep our little patients warm, happy, and safe under anesthesia. Indeed, it's all in the little things, and you have taught us how to know it well so we won't sweat the small stuff. Thank you,
Professor. Very much.
Yeah.
And it was
Liz,
really
I end this symposium.
This session.
Yeah. With warm wishes to everyone. Stay safe.
This video provides instructions for using the 3M Bear Hugger Pediatric Underbody Warming Blanket Model 55501 and the 3M Bear Hugger Large Pediatric Underbody Warming Blanket Model 55000 and is intended for clinicians only. The Bear Hugger Pediatric Warming Blanket assists healthcare professionals with managing patient temperature in the perioperative and other clinical environments. Prior to use of the 3M Bear Hugger Temperature Management System, consult detailed product indications, limitations, safety information, and instructions in the provided instructions for use, operator's manual, and preventative maintenance manual. The 3M Bear Hugger Pediatric Underbody Warming Blanket Model 55501 and the 3M Bear Hugger Large Pediatric Underbody Model 55000 are two of the 3M Bear Hugger Underbody Specialty Warming Blanket options. The versatile design of these blankets provides unrestricted patient access. Both blanket models have fluid outlets, which enable excess fluids to flow through and away from the patient to the pad or sheet underneath the warming blanket. This can help minimize fluid pooling on the patient's skin. The blankets should be set up on the operating room table before the patient arrives in the operating room. First, open the peel pouch and remove the warming blanket. Unfold the blanket on the OR table. As you unfold the blanket, remove the clear head drapes and set aside for later use. Note the sticker at the head end of the blanket, indicating which end is to be placed at the head of the bed. The warming blanket should be placed with perforations facing towards the patient and with the adhesive strip side towards the OR table pad. Next, once the blanket is positioned, use the adhesive tape strips on the underside of the warming blanket to secure the blanket to the OR table to prevent it from slipping. Then tuck the warming blanket's side or tuck flaps under the mattress or operating table pad to provide stability. The blanket is now ready for the patient. Place the patient on top of the blanket while it is in the non-inflated state, ensuring that his or her head is positioned on the head area of the warming blanket. Apply the clear drapes as desired for the surgical procedure. Use adhesive tape strips to adhere the drape or drapes in a place along the upper and/or lower edge of the prep site and/or over the patient's head and neck. The head drape should be used only if the patient is intubated and ventilated. If a safety strap is used, ensure not to occlude the air channels on the blanket. Once the patient has been properly placed on the warming blanket, it is time to begin warming therapy. Hose ports are provided at either end of the warming blanket for clinician preference. Remove the hose port card from the port you wish to use. Ensure that the card is placed in the unused port. Insert the end of the Bear Hugger warming unit hose into the hose port. Use a twisting motion to ensure a snug fit. A visual marker is located around the midsection of the hose end to guide the depth of hose insertion. Support the hose to ensure a secure attachment. Connect the warming unit to a properly grounded power source. Select the desired temperature setting on the warming unit to initiate warming therapy. Select the desired fan speed, high or low. Turn the unit off or to standby mode to discontinue warming therapy.